Welcome to the deep dive. Today, we're really getting into a critical topic from some detailed medical sources, pulmonary embolism. We've got the key chapter here ready to break down what matters for you. Think of this as, well, your guide through the complexities. What is a PE? Who's most likely to get one? How do doctors find it? And what do they do about it? We want to pull out those key insights, maybe give you a few aha moments.
Yeah, this source material does a great job laying out the whole picture. From where these things often start deep in the veins, right through to the tricky diagnostic puzzles and the different ways it's managed and prevented.
All right, let's dive in then. Pulmonary embolism, what exactly is that?
Okay, so basically, a pulmonary embolus is usually a blood clot. The medical term is thrombus that breaks off from somewhere else, travels through your veins.
Travels where?
Right, travels up towards the heart and then gets pumped into the lungs where it gets stuck in the pulmonary arteries.
And these clots, where do they typically come from?
Around 90%. They start as a deep vein thrombosis, a DVT, usually in the big veins of the legs, the iliofemoral system, but sometimes the right side of the heart or pelvic veins too.
Okay, and this blockage, it's not minor, is it? What's the real impact here?
No, definitely not minor. It's a major blockage. It obstructs blood flow, meaning that part of the lung gets air, but the blood can't get there to pick up oxygen, so oxygenation drops. It's quite serious.
And the source gives some pretty stark numbers about how serious. Why is this something we really need to focus on?
Well, one huge point is it's the third leading cause of cardiovascular death. Only heart attacks and strokes kill more people from cardiovascular causes.
Third. Wow.
Yeah. And maybe even more importantly, the source suggests it might be the most common preventable cause of death globally.
Preventable, that's huge, especially for something so high up the list. If someone is diagnosed, what are their chances?
The 7-day survival rate for those who get diagnosed is around 59%.
But the source also flags a big concern about the ones that don't get diagnosed, right?
Yes, and this is really critical. Most people who actually die from PE, sadly, haven't had a diagnostic workup, haven't had prophylaxis at the preventative measures. The true number of cases, we actually don't know because so many are missed. Autopsy rates are low too. It's a hidden problem in many ways.
But there has been some positive movement, at least in non-fetal cases.
That's right. The source mentions a 37% drop in non-fatal PEs. And the thinking is that's down to better DVT diagnosis, better treatments, more prevention being used, and, just more public awareness.
So awareness and prevention really do make a difference.
Clearly. And there's a big cost factor, too.
Yes, the financial side. What does the source say about that?
The estimate is over $1.5 billion a year in associated healthcare costs, about $30,000 per case on average. Compare that to prevention costs, which are around $3,000 per patient.
That's a massive difference, really underscores the value of prevention.
Absolutely.
Now, we've been talking about blood clots, BVT, but it's not always a blood clot, is it?
Correct. The vast majority are thrombotic from DVT, but less than 10% are non-thrombotic emboli.
Non-thrombotic. So what else can block those arteries?
Well, the source lists some interesting ones. Air embolism, like from certain medical procedures. Amniotic fluid embolism, a rare but serious complication of childbirth. Bacterial emboli, maybe from infected heart valves.
Bacteria traveling like that.
Yeah, clumps of bacteria. Also fat emboli, often after a bad break of a long bone like the femur. And even foreign matter stuff getting into the bloodstream from trauma, IV lines, sometimes illicit drug use. The lungs act as a filter, you see.
Wow. Okay, so let's get into the mechanics. How does this blockage actually mess things up in the lungs, the pathophysiology?
So what happens is you get this mismatch. The lung segment is ventilated air is getting in.
You're breathing okay into that spot.
Right, but it's not perfused blood isn't flowing through it because of the clot. The source calls this physiologic dead space ventilation. Air is present, but no gas exchange can happen there.
Like a blocked pipe in a radiator. Air flows over it, but the hot water isn't getting through.
Exactly. Good analogy. Yeah. And the body might react with something called reflex bronchospasm, where the airways tighten up in that area. It seems like a local reaction, but it can actually shunt air away from healthy lung tissue and make overall oxygen levels worse.
And what about the pressure inside the lungs' blood vessels?
If a large chunk of the pulmonary vascular bed gets blocked, the source suggests about 2/3 needs to be obstructed. Then you can get pulmonary hypertension. High blood pressure in the lungs. This might be from one massive clot or sometimes a shower of smaller ones.
Can the lung tissue itself actually die off? What's pulmonary infarction?
Yes, infarction is tissue death due to lack of blood supply.
Yeah.
It's actually less common in PE than you might think.
Oh, why is that?
Because the lung has a dual blood supply. It gets blood from the pulmonary arteries and the bronchial arteries,
Hmm.
kind of a backup system. But infarction is more likely if that backup isn't great, or if the lung tissue is already compromised, maybe by infection or congestion. The sharp chest pain some people feel can be from this ischemia, this tissue struggling for blood.
So does the size of the clot determine everything? Big clot, big problem.
Size is definitely a major factor in symptoms and outcome, yes. But the source stresses it's also really tied to the patient's overall health. A small embolus might cause minimal issues in a healthy young person, but it could be catastrophic for someone with severe COPD, for example.
Right. Context matters.
Absolutely. And remember, lots of small emboli can add up to have the same impact as one large one.
Which brings us to the really scary one, the saddle embolus.
Yes, the massive PE, often called a saddle embolus. This is a large clot that gets lodged right where the main pulmonary artery divides to go to each lung, like a saddle on a horse. It essentially blocks almost all blood flow out of the right side of the heart.
And the consequences are immediate.
Devastatingly so. The source describes sudden, profound shock, severe chest pain, very rapid heart rate, plummeting blood pressure, cyanosis, the skin turning blue from lack of oxygen confusion, or stupor, fainting.
Just a total collapse.
Yes. And tragically, death can happen incredibly quickly, within minutes. Sometimes before medical help can even arrive. It highlights the extreme end of the spectrum for PE.
That's really chilling. Okay, let's shift to who is most vulnerable. Who gets PEs?
Well, the risk factors are essentially the same as for DVT because that's the starting point for most PEs. It comes down to something called Virchow's triad.
Virchow's triad sounds important.
It is. Named after Rudolf Virchow, a 19th century physician. He identified 3 key contributing factors. Venous stasis, meaning blood flow is slow or sluggish.
Like when you're stuck on a long flight.
Exactly, or bed rest. Second is vessel wall injury damage to the lining of the vein. And third is hypercoagulability. The blood itself is more prone to clotting than normal.
Okay, so let's break down that triad into specific risks the source mentions.
Sure, there's quite a list. Age is a big one. Risk goes up after 40, triples after 70, immobilization, bed rest, long travel, even sedentary jobs. Surgery is a major trigger, especially orthopedic surgery like hip or knee replacements, but also major chest, abdominal, or pelvic operations. Obesity, pregnancy and the period right after birth. Also taking estrogen, like in birth control pills or hormone replacement therapy. Having a stroke or a spinal cord injury. Major trauma, especially pelvic or hip fractures. Having 5E lines or central venous catheters can injure the vein wall. Cancer, some tumors release substances that promote clotting. Inherited clotting disorders, things like factor V Leiden, protein C or S deficiency. These run in families. Smoking definitely increases risk. Other health conditions, heart failure, kidney disease, dehydration, inflammatory bowel diseases like Crohn's or colitis, even chronic lung disease itself. Other health conditions, certain medications, some types of chemotherapy, again, estrogen-containing drugs.
That's a lot of potential factors. Does the source single out any conditions as being particularly high risk?
Yes, it specifically mentions congestive heart failure as maybe the single most important condition predisposing someone to DVT and PE. Others highlighted are, again, postoperative states, especially hip, major abdominal pelvic surgery, the postpartum period, having had a DVT or PE before, having varicose veins, long bone fractures, serious abdominal infections, diabetes, sickle cell anemia, and malignancy.
And it also looks at risk across the lifespan, different factors at different ages.
Right, it points out things relevant to younger adults, maybe contact sports injuries, contraception choices, substance use. For women of childbearing age, there's contraception, again, pregnancy itself, and the complexities if they need anticoagulation like warfarin during pregnancy. And for older adults, maybe hormone replacement therapy, increased risk of falls causing trauma, memory issues affecting taking meds correctly, having multiple other health problems and medications.
Polypharmacy.
Exactly, polypharmacy. And having had prior clots, it really drives home that risk assessment needs to be individualized,
Absolutely. So given all this, what about prevention? Since it's potentially so preventable, what does the source recommend?
Prevention is key. On a basic level, primary prevention is about healthy lifestyle. Stop smoking, maintain a healthy weight, get regular exercise, control blood pressure. Public education about these risks is also vital.
And for specific situations, say if you know you have a family history.
Yeah, if there's a strong family history, testing for those inherited clotting disorders might be considered. Then there are non-drug methods. Simple exercise, the source uses the phrase ambulate or elevate, which I like. Ankle rotations if you're sitting for long periods. Graduated compression stockings are important, especially if you've had DVT or have venous insufficiency. They even specify different pressures, like 20-30 millimeter Hg or 30-40 millimeter Hg, depending on the situation.
What about for flying? So many people worry about that.
Good practical advice there. Drink lots of water, get up and move around when possible, avoid alcohol, and consider wearing compression stockings, especially on longer flights. Simple things can make a difference.
And for patients in the hospital who are often stuck in bed.
For medical patients with risk factors, the focus is on getting them walking as soon as possible. Using compression stockings, often a lower pressure like 18-20 millimeter Hg, and frequently using preventative medications called pharmacologic prophylaxis. That usually involves low doses of unfractionated heparin or, more commonly now, low molecular weight heparin, LMWH. Surgical and trauma patients often get even more rigorous prevention protocols.
Okay, let's switch focus. If someone is worried they might be having a PE right now, what should they look out for? What are the signs and symptoms?
Well, here's the challenge. The source really emphasizes that the signs and symptoms can be super variable, often subtle, and frequently nonspecific, meaning they could be caused by lots of other things. It really depends on the person's health and the size of the clot. But sudden, unexplained low blood pressure, chest pain, or significant trouble breathing should always raise alarm bells for PE.
Okay. Based on the studies mentioned in the material, what are the most common things people feel? The subjective symptoms.
Top of the list, according to one study cited, is sudden shortness of breath dyspnea, found in about 73% of cases. Then pleuritic chest pain, pain that's worse with a deep breath in 66%, cough in 37%, coughing up blood, hemoptysis is less common, around 13%. People might also feel restless, anxious, lightheaded, sweaty. Notice their heart racing or breathing faster.
And what might a doctor find during an exam? The objective signs.
The most common findings are tachypnea, breathing fast, and hypoxemia, low oxygen levels seen in about 70%. Crackles or rales in the lungs on listening, about 51%. Tachycardia, fast heart rate in 30%. Maybe some specific heart sounds. But, and this is crucial, the source states very clearly, no single clinical finding is sensitive or specific enough. You can't diagnose PE just based on the exam. These signs can be absent or they can be caused by other conditions.
So you need tests. What are the key diagnostic tools?
All right, tests are essential. The source covers several categories. First, sort of bedside tests or initial labs. A chest x-ray is usually done. It's often abnormal but not specific for PE. It might show an area of infarction or rule out other things like pneumonia. An ECG or electrocardiogram is also routine. Again, often non-specific changes, maybe signs of strain on the right side of the heart. It's helpful to rule out a heart attack. Arterial blood gas, ABG, can show low oxygen, but importantly, a normal ABG doesn't rule out PE. Pulse oximetry, that little finger clip, a reading below 95% oxygen saturation is definitely concerning. And then non-invasive venous studies, usually an ultrasound of the leg veins. This is really useful. If you find a DVT in someone with symptoms suspicious for PE.
You've likely found the culprit.
Exactly. As happened in the case study with JD. A positive leg ultrasound might mean you don't need further lung imaging, especially if the clinical picture fits.
Okay. What about the D-dimer test? That comes up a lot.
Yes, the D-dimer assay. It measures a breakdown product of blood clots. Its main value, as the source highlights, is in ruling out PE. If the D-dimer level is low, typically under 500 ng/ml, and the doctor wasn't highly suspicious of PE to begin with.
Based on risk factors and symptoms.
Right. Then a negative D-dimer makes PE very unlikely. It has a high negative predictive value.
So negative D-dimer is good news in low-risk folks. But what if it's positive?
A positive D-dimer doesn't confirm PE. It just means there's some clotting and breaking down happening somewhere. Lots of things can raise D-dimer. Infection, inflammation, cancer, recent surgery, trauma, pregnancy, heart failure, kidney failure. It's sensitive but not specific.
So if the D-dimer is positive, or if suspicion was high from the start, you need to actually look at the lungs with imaging.
Correct. That's where imaging comes in. T methods include the VQ scan ventilation-perfusion scan. Uses nuclear medicine to compare airflow and blood flow. A mismatch, good air, bad blood flow suggests PE. But the source points out a big limitation if you have underlying lung disease, like from smoking.
Like JD in the case study.
Exactly. Pre-existing lung problems can mess up the ventilation part, leading to scans that are hard to interpret, indeterminate, or even false positives. That's why it wasn't the first choice for him.
Makes sense. So what's often preferred now?
Spiral computed tomography, or CT scan, specifically a CT pulmonary angiogram, the CTPA, using TD contrast dye. The source describes this as the test of choice in many places today. Gives direct images of the clots in the pulmonary arteries. It's generally quite accurate, though maybe less sensitive for very small clots way out in the periphery. MRI can be used, but it's less common, more expensive, takes longer, difficult for unstable patients. Echocardiography and ultrasound of the heart is valuable too. It doesn't see the clot directly, but it can show if the right side of the heart is struggling under the strain of the blockage. The source says this is abnormal in about 80% of significant PE cases.
Is there an ultimate gold standard test?
Pulmonary angiography is traditionally called the gold standard. It involves putting a catheter right into the pulmonary arteries and injecting dye. It gives the clearest pictures. But the source really stresses this. It's invasive, it has risks, bleeding, arrhythmias, kidney issues from dye, especially in sick patients. You need special expertise and equipment. It's expensive. So it's not for routine diagnosis, reserved for complex cases where other tests are inconclusive.
Yeah, that case study with JD really pulls these diagnostic threads together. His symptoms after bed rest, his risk factors age, smoking, family history, and the initial findings all screamed PE. And the source explains the logic. Smoker, so VQ might be unreliable. Let's do the leg ultrasound first, maybe find a DVT, then move to the spiral CT for a direct look at the lungs.
It illustrates the clinical reasoning process very well.
Okay, so diagnosis confirmed. What happens next? What are the treatment goals?
Two main goals, really. First, immediate stabilization. Support the heart and lungs while the body starts to deal with the clot. That resolution process usually takes 10 to 14 days. Second, and just as vital, prevent it from happening again. Prevent recurrence.
What are the immediate supportive measures?
Prompt diagnosis leads to immediate supportive care. Things like sitting the patient up, elevating the head of the bed, helps breathing, giving supplemental oxygen, securing 4V access for fluids and medications, using pain relief like opiates carefully, watching out for respiratory depression, being cautious with 5V fluids too much can overload the already strained right heart, applying those compression stockings, and maybe using medications to support blood pressure or control heart rhythm if needed.
And the main medical treatment, the cornerstone.
Heparin. The source calls it the cornerstone. Its job isn't really to dissolve the existing clot. The body's fibrinolytic system does that over days to weeks, but to stop the progression of the clot and prevent new clots from forming while the body heals. It's very effective at preventing early recurrence, with rates less than 5%. Though sometimes if clots don't fully dissolve, long-term issues like chronic pulmonary hypertension can develop.
Now, there was a point made about heparin dosing, a common mistake.
Yes, both the source text and the case study mention this. The most common mistake is to give too little heparin initially and too much heparin later. Initial requirements are often high because there's a large clot burden, then they decrease. That's why frequent monitoring of clotting times, like the APTT for standard unfractionated heparin, is so critical in the first day or two.
What about the low molecular weight heparins, LMWH?
They are often preferred now. The source describes them as generally safer and more effective than unfractionated heparin, if dosed correctly based on weight. A big advantage is they usually don't require routine lab monitoring like APTT, but you still need to be careful with kidney problems with low platelets. Fondaparinux is also mentioned. It's a synthetic drug, a factor Xa inhibitor. Another option for prevention and treatment, potentially fewer bleeding issues in some studies, once daily dosing. But again, specific contraindications like severe kidney impairment and drug interactions to watch for.
So that covers the initial phase. What about longer-term anticoagulation?
That's usually warfarin, an oral anticoagulant pill. It's typically started at the same time as the heparin. The goal is to achieve a target level of blood thinning measured by the INR test, aiming for an INR between 2 and 3. The heparin, or LMWH fondaparinux, is continued alongside warfarin for several days, usually about 5 days, and until the INR has been in the target range for at least 24 hours. Then the heparin is stopped. Warfarin treatment usually continues for at least 3 to 6 months.
A little longer.
Yes, sometimes lifelong, especially if someone has ongoing risk factors like certain genetic conditions or if they've had multiple PEs.
Okay. What about those clot buster drugs? Fibrinolytic therapy.
Right, fibrinolytics or thrombolytics. These drugs do actively dissolve the clot. The potential pluses are rapid dissolution, faster improvement in hemodynamics, blood pressure, heart function, maybe better long-term right heart function. But the major downside is a significantly higher risk of bleeding.
How much higher?
The source says double or triple the rate of major bleeding compared to heparin alone, and includes a roughly 1% risk of intracranial hemorrhage bleeding in the brain, which can be catastrophic. So it presents a real dilemma, right?
Sure.
Weighing the potential for faster improvement against that serious bleeding risk. And importantly, the source notes that studies haven't consistently shown that putlytics actually improve overall survival compared to heparin alone, even though they break down clots faster.
So when are they used?
Generally reserved for the most severe cases. Proposed indications include massive PE or submassive PE, where there's evidence of right heart strain or unstable vital signs, hemodynamic compromise. Also considered if standard heparin therapy seems to be failing, or sometimes for very large DVTs. There's also a list of absolute contraindication situations where they absolutely shouldn't be used, like active internal bleeding, recent stroke, or major surgery, and relative contraindications where the risk is very high. The main drug mentioned currently available is RT-PA alteplase.
And managing patients getting these drugs requires extreme care.
Utmost care. Minimizing bleeding risk is the top priority. Careful patient selection, close lab monitoring, avoiding any unnecessary punctures or invasive procedures, holding firm pressure after blood draws, and strictly avoiding other anticoagulant or antiplatelet drugs during the infusion. Plus monitoring for side effects like bleeding, allergic reactions, fever, blood pressure drops, or falling platelet counts.
What if drugs aren't enough or someone can't take them? Are there surgical or procedural options?
Yes, surgical management is discussed. One option is placing an inferior vena cava filter, an IVC filter.
What does that do exactly?
It's a small, cage-like device inserted, usually via catheter,
Yeah.
into the IVC, the big vein bringing blood back from the legs. It acts like a sieve to physically trap large clots traveling from the legs, preventing them from reaching the lungs.
When would that be done?
Indications include patients with DVT or PE who have absolute contraindications to anticoagulation, like active bleeding, sometimes used for prevention in very high-risk patients, major trauma, certain cancers, or if anticoagulation fails to prevent further PEs. Some filters are permanent, others are designed to be retrieved later. But they're not without potential issues. The source lists complications like clots forming below the filter, long-term leg swelling, venous insufficiency, the filter moving, or even the filter itself getting clogged with clot. And importantly, placing a filter doesn't usually replace the need for anticoagulation if the patient becomes able to take it later.
And what about actually going in and removing the clot itself?
That's pulmonary embolectomy. This is generally a last resort for life-threatening massive PE, especially if the patient is unstable and can't get or hasn't responded to low medical therapy. As we discussed, sadly, the mortality is high, and many patients may not even survive long enough to get to surgery. It can sometimes be done via catheters threaded into the pulmonary arteries or through open heart surgery. It's very rarely done electively for chronic, unresolved clots.
Okay, so someone gets through the acute treatment, they're going home. What do they need to know to stay safe and prevent this happening again? Patient teaching seems critical here.
Absolutely crucial. The source lays out key points. First, making sure the patient understands what PE is, their specific risk factors, and the goals of their treatment, like the target INR range if they're on warfarin.
And the medications, especially warfarin, require careful explanation.
Definitely. Teaching about the dose, timing, side effects like easy bruising or bleeding gums, critical interactions avoiding aspirin or NSAIDs, that's cleared by the doctor, and the dietary interactions with warfarin, especially vitamin K. Not avoiding it completely, but keeping intake consistent and moderate. Avoiding things super high in vitamin K like green tea and tobacco, and generally avoiding alcohol. If they're using injectable heparin like LMWH at home, they need proper instruction on self-injection.
What warning signs should send them straight back for help? This seems vital.
Life-saving information, really. The source lists clear signs. Signs of infection, increased leg pain, swelling, warmth, or redness. Seek emergency care for suspected DVT recurrence. Chest pain, sudden shortness of breath, rapid pulse, sweating, anxiety, fainting, coughing up blood. Seek emergency care for suspected PE recurrence. Also, recognizing signs of stroke, sudden numbness or weakness on one side, facial droop, trouble speaking or seeing, loss of balance requires immediate attention while on anticoagulants. And knowing when to seek care for bleeding, distinguishing minor bruising from major bleeding that needs urgent assessment.
And just general advice for living day to day.
Maintaining a healthy weight. Regular, moderate activity, walking, cycling, swimming are good. Avoiding sitting or standing still for too long. Elevating legs when resting. Not crossing legs for long periods. Avoiding tight clothing that could constrict blood flow. And of course, safety precautions due to bleeding risk on anticoagulants. Protecting feet, being careful with knives or razors, using an electric razor, wearing a helmet for certain activities, and always carrying identification like a medical alert bracelet saying they're on anticoagulation therapy.
Going back to JD, the case study patient, what teaching would be key for him?
For JD, given his smoking history, the trauma, the immobility, the family history, the teaching would really focus on smoking cessation, understanding all his risk factors, getting appropriate activities safely, the diet specifics for warfarin, all those safety measures, and being crystal clear on when to call the doctor versus heading straight to the ER. And that medical alert bracelet is specifically mentioned as important for him.
Lastly, the source briefly touches on the future. Where is research headed with PE?
Yeah, areas for future study include better understanding the genetic links to clotting disorders, getting deeper knowledge of the coagulation cascade itself, developing improved, faster, maybe more accessible diagnostic tools, and finding new anticoagulant drugs, especially safer options or ones for patients who can't use current therapies.
So, wrapping this up, we've taken a deep dive into pulmonary embolism. It's clearly a serious, potentially fatal condition, often starting with DVT, third leading cause of cardiovascular death.
But, and this is the hopeful message from the source, it's also highly preventable in many cases and definitely treatable when caught. Understanding those myriad risk factors from lifestyle and genetics to medical history is the first step towards prevention.
And recognizing that the symptoms can be tricky and nonspecific, knowing what the diagnostic tests can and can't do, and understanding the treatment options from heparin and warfarin as the mainstays to more specialized approaches like lytics or filters, that knowledge is power.
Absolutely. And that emphasis on patient education for the long haul, preventing recurrence, it's huge. Lifestyle changes, medication adherence, safety awareness, these are truly key for long-term health after a PE.
It really highlights the connections, doesn't it, between our daily habits, our genes, the incredibly complex systems in our bodies, and the ongoing advancements in medical treatment and care.
Definitely. And here's something to think about based on what we've discussed. The source states the true incidence of PE is unknown, largely because so many cases, especially fatal ones, go unrecognized clinically. Most who die haven't had diagnosis or prevention. So the question to ponder is, what does this stark reality tell us about the potential impact, the lives that could be saved through much broader public awareness, more systematic risk assessment in healthcare, and more consistent application of preventative strategies?
A really important question to consider. We hope this deep dive into the source material has provided a clearer, more comprehensive understanding of pulmonary embolism.